like knowing everything from the symptom side of things, that's more for your CMS classes, not so much for everything else, because everything else kind of teaches all the ancillary parts. EKG and medical imaging is all your technical skills, how to read an EKG, how to read all your imaging, but it's all helping you to diagnose and treat a patient that you learn about in your CMS classes. So you won't have very much like symptoms in this class, but obviously we know all the symptoms from this class, but I'm not going to ask you like to diagnose anything because we haven't gotten there yet. So yesterday we finished up the vasculature stuff, went through high blood pressure, atherosclerosis. So for example, we're going to do neuro together in the winter. We'll bring up cerebrovascular disease as it relates to atherosclerosis of the cerebral arteries. But I'm not going to go through the development of atherosclerosis again because we've already done it now. In cardio, they'll go through coronary artery disease. Nephro, you'll go through that renal vascular hypertension stuff. Talking about renal artery stenosis. Again, it's atherosclerosis of the renal artery that's causing these issues in the renal system. And you'll get all that in nephrology. But again, the underlying cause is atherosclerosis and one of the risk factors and so on and so forth. So when you're studying these things, that's what you're trying to do. The last little bit is on shock, what happens to our vessels when we are in different types of shock. And then also we'll finish up with vascular problems, clots, thrombi, and stuff like that. So when it comes to shock, basically the cardiac system cannot, pump blood to the entire body, and your body goes into shock. Either it's not adequately perfused, or relative inadequate cardiac output. It's not enough coming out to really do anything. Yes, you do have cardiac output, but it's not enough to perfuse the body. There are 4 main groups of shock and types of shock. So hypovolemic is one of them, distributive shock, cardiogenic, and then your obstructive shock. So we'll go through each one individually. The pathophysiology is pretty much the same except for one of them, but we'll go through what are the common things with all of them. The biggest thing is the underlying cause. Why is this patient in shock? What happened to them? What's the history of this patient? Why are they here? As we go through each one, it'll make more sense as far as why knowing that history is very important. What it comes down to, inadequate tissue perfusion. When you don't have a lot of tissue perfusion, there's lack of blood supply, meaning there's lack of oxygen. So we have to go into anaerobic metabolism, so we start getting lots of lactic acid buildup. This lactic acidosis depresses the myocardium, decreasing the peripheral response to catecholamines. What is the job of these catecholamines, the norepi and epi, with regards to the vasculature? What's it going to do? Vasoconstrict. But now I'm telling you that because of this lactic acidosis, these catecholamines aren't going to have their normal effect on the body. So if the catecholamines aren't working, what's going to happen to your vessels? They're going to dilate and get big. Okay. We do get some vasoconstriction. Remember, it does vasoconstriction, what the catecholamines are going to do. Shifts blood away from the outside back to the heart and the brain into your core. Heart rate goes up from increased myocardial metabolism, starts going a little haywire under these situations. Cool, pale, clammy skin from the vasoconstriction, shunting that blood away from the body. Blood is warm, the blood's going away, so your hands start to feel cool. Vasoconstriction also causes decreased renal perfusion, reducing our GFR, so we're not going to be producing a lot of urine anymore. And this is what's called pre-renal azotemia. Azotemia just refers to pretty much like kidney failure. If it's pre-renal, that means the issue that you're having is developing before it gets to the kidneys. Okay. We also get our carotid, and yes?
So we're vasoconstricting in like the peripheral, like arms, legs, whatever, but then vasodilating
In the blood in the brain to keep the core.
Okay.
We have our carotid and aortic baroreceptors, but they can fail when the blood pressure is less than 70, meaning those receptors aren't going to be responsive to that pressure anymore to help you get that pressure back up again. It's dropped too low. Circulating levels of our vasopressor hormones are increased. ACTH, all this whole aldosterone thing to bring water and sodium back. If we have shock due to, let's say, hypovolemia, low blood volume, no volume, there's no pressure in the system. Do you see why aldosterone going up is going to help that? Going to bring water back into the blood, increasing your blood volume to try and maintain the pressure. That's the goal of these things, to maintain that pressure. So the first one is hypovolemic shock, low volume of blood. You don't have enough blood to fill the vascular system. What are some major causes? Hemorrhage is obviously a big one. If you cut your leg and your femoral artery is now open, you're going to be losing a lot of blood real fast. You'll go into hypovolemic shock soon because there's not enough blood to pump the system and perfuse your organs. Trauma will do it as well, depending on where you are. If it's internal bleeding, you're going to keep losing blood and you may go hypovolemic from that. Or is it external damage? You got into a car accident and now blood's going everywhere. Surgery, okay, a lot of bleeding going on during surgery. Liver surgery has a lot of blood loss during that. They get like 10 to 15 units of blood during a liver surgery, maybe even more, because of the amount of blood that goes through the liver. You lose some. Burns. Burns loses a lot of plasma. So if you're losing your plasma, what's happening to your blood volume? Decreasing. So you have to be very careful for hypovolemic shock in people with very, very high percentage, full thickness burns on their body. Fluid loss is a huge risk for those patients. If we know we're losing fluid, our pressure is going to drop. They may go into hypovolemic shock later on. And rarely fluid loss from vomiting or diarrhea. They can get dehydrated from that real fast. Also, if they're an elderly or a baby, they can get dehydrated very fast. Watch their pressures, make sure it doesn't go too low, then the body can't respond to that. So these are some causes for hypovolemic shock. So this is what happens when we have hypovolemic shock. Decreased intravascular volume. We don't have enough volume of blood anymore because we're losing it somewhere. We have an opened wound. Remember, normally the cardiovascular system is a closed system. Whatever goes into the heart comes out of the heart. It's closed, same amount of blood travels. But now we have an open wound somewhere, so yeah, the heart is continuously pumping blood, but with every heartbeat, we're losing more blood as well. So volume goes down, stroke volume goes down, obviously cardiac output goes down as well. Now, when we have this drop in cardiac output, there are two things that's going to happen. One, we get this issues with the volume on this side. We have to worry about the volume of blood. We want to expand the blood. We're hypovolemic, severe dehydration, or we're bleeding out somewhere. But we want to try and expand our blood volume as much as we can. So we shift interstitial fluid out of the interstitial space and dump it into the plasma as well. I don't know if you remember, but day one of physio, we talked about the different compartments of extracellular space, interstitial, and intracellular, and we talked about fluid resuscitation, how if we have a lot of fluid stored in our interstitial space as like a reservoir in case we need it. In this case, we need it, so we get that fluid out of the interstitial space and dump it into the plasma. The problem is afterwards, you got to give a lot of volume of saline to replenish those interstitial stores of fluid so you have your reservoir up again and you've maxed out your blood volume as well. So lots of fluid, you're going to shift all that fluid out. Aldosterone, ADH comes out. Okay, by now, hopefully you should know what ADH and aldosterone do to help with blood volume and splenic discharge as well, but the goal is to increase volume. We got to get our blood volume up. The other thing that happens with this reduced cardiac output, what's the other variable for cardiac output? Stroke volume and heart rate. So if our stroke volume is dropping to maintain cardiac output, we got to increase our heart rate. So catecholamines come out, and they're going to help with our heart rate and contractility. Okay, what receptors are they going to attach themselves to? Alphas and betas. Okay? So we've increased the contractility, the heart rate. We're trying to increase the volume. The main goal, get our cardiac output up. But the problem is this, especially if we have, let's say, an open wound. We're trying to get our cardiac output up. But as we're doing that, because we have an open wound, we're continuously losing more and more blood. With every beat, because you have an open wound, you're oozing every single heartbeat, which is going to further reduce cardiac output, further reducing tissue perfusion, and then finally, when you start getting into this lack of tissue perfusion, you start getting these end organ damage. You start getting changes in your BUN and creatinine due to kidney stress, and so on and so forth. Also, with this catecholamine release, we also get an increase in systemic vascular resistance. What hemodynamic property is that going to alter now? Afterload. It's a pressure problem. If I'm increasing my SVR, what's happening to my afterload? Increasing as well. If I increase my afterload, what happens to my stroke volume? You see the cardiac output dropping here? All connects. So the goal, we want to bring up our blood volume. We're trying to find ways that the body is going to do to stave off this massive dehydration, hypovolemia, this shock, to try and bring back our cardiac output. The next one is distributive shock. The major difference between distributive shock and the other three types, warm. In a distributive shock, the body is still going to feel warm. In all the other three, they're going to have those cool, pale, clammy hands due to the type of shock. But in distributive, they are warm because they have vasodilation. So this massive vasodilation, all these vessels just skyrocket open. So obviously you still get perfusion to your skin, you're going to feel warm. There's three types of distributive shock. One is your anaphylactic shock. This is from your histamine. Okay, an anaphylactic shock, what type of hypersensitivity reaction is it? Type 1. Okay, type 1 hypersensitivity reaction due to all this massive dump of histamine into the system, dilate your vessels, and so forth. The next one is neurogenic shock. These are usually found in head and spine injuries. Okay. Sudden loss of autonomic activity, causing massive vasodilation, pooling of the blood in the extremities, in the veins, in the legs, and they get syncope, can occur from a decreased cardiac output. This is also your postural syncope. When people stand up too fast, they get lightheaded and dizzy, they pass out. It's neurogenic. It's the nervous system is causing the shock to start. And the last one is your septic shock, which is most common form of death in the ICU. So we learned about septic shock from the stages of sepsis. What stage is septic shock? The last one, okay? So that's distributive shock. Neural, they're going to be falling off a ladder somehow in the vignette. They're going to give you some clues as far as what happened to that patient. So for anaphylactic, oh, they ate some peanuts and now they're going to have problem breathing. We know that's an anaphylactic shock. That is a form of a distributive shock. The next one is cardiogenic. What do you think this one is? The heart just stops working. There's no pump anymore. It's weak. It's not able to pump blood to the body. So the cardio is the source of the shock in this one. What are some examples that we learned about? What would cause it? A lot of that ventricular free wall to not work anymore. Left coronary MI, mainly what vessel? The left main. Remember, the higher you up, the more proximal you are, the bigger the territory that you're going to lose. The left main supplies the circumflex and the LAD, the entire anterior and lateral wall of the left ventricle. So if you have a left main disease due to massive MI, the heart pump is not going to work anymore, and that patient can go into a cardiogenic shock. So it says here, inadequate pumping of the heart to meet the demands of the body, often due to extensive LV infarct. Left main, or even LAD. Circumflex, not so much because it's just a lateral. Yes?
Can tamponade do this as well?
A little bit, yes. You can have some problems with that, but not, the pump is still working. It's just they can't fill. So they can squeeze, it's just not going to be enough blood. Signs and symptoms, again, if the pump is not working, we get signs of left ventricular or left-sided heart failure. So where's that blood going to back up to? The lungs. And so you get lung congestion of the lungs and the viscera because you are essentially putting them in right into a left ventricular heart failure. That's immediate in an acute situation. All those compensatory mechanisms that we learned about don't have time to happen. And now we get pump failure. So if it's so the pump failure is going to increase the oxygen demand because now we have a massive ischemic event. Oxygen demand for the heart is skyrocketing now. It needs more oxygen, needs more blood, but it's not there because you have a massive MI, which leads to further pump failure, which leads to further ischemia, further oxygen demand, further pump failure. It gets worse and worse and worse. Pump failure also leads to reductions in cardiac output, which further decreases coronary perfusion. What's coronary perfusion? The heart muscle itself needs to be supplied. Okay? We know that this end diastolic volume, what's going to happen to that now? Increase. The heart's not bumping. So that end diastolic volume is going to stay high. That's going to add to some wall stress because now remember, when the heart stretches, it's going to want to recoil and squeeze harder to help with all that, but now it can't. So it causes some more issues. End result, it's going to be this lactic acidosis again. We're anaerobic metabolism. And the end result, the byproduct is lactic acid. So this is cardiogenic failure. It's got to be some sort of history in there about the pump is not working, the heart is not working, massive MI, nothing, the heart is not working. The last one are called obstructive shocks, and there's two different types. One is pulmonary or vasculature. This is usually from right-sided failure from a massive PE, a pulmonary embolism. It's obstructing the blood flow to an area because now you've obstructed it. That's why a massive pulmonary embolus, we'll learn about a little bit later today, but a clot is in your leg. Is it going to be in the artery or the vein? Vein. So the vein, if it's in your femoral vein, where is it going to come up from? IVC into what? Atrium. Then what? And then the lungs. That's why a deep vein thrombosis leads to a pulmonary embolism because you're on that side of the system. Strokes on the opposite side, now we're on the arterial side. We're on the left atrium for clots, right? With like atrial fibrillation. If that clot breaks free of left atrium, where does it go next? Left ventricle. Where does that go? Aorta, right to the brain. That's why you get strokes with atrial fibrillation. You don't get a stroke from a DVT. You're on the opposite side of the system. You can't get over there. There's no way a clot from the venous side is going to make its way to the arterial side. Pulmonary hypertension. Okay, right ventricle can't overcome these huge pressures in the lung vessels, and you get a obstructive shock, right-sided failure. The other one is a mechanical issue causing obstructive shock. Clinically, it's going to look like hypovolemic shock due to decreased preload versus an actual pump failure. This issue is preload. There's something obstructing, preventing blood from getting into the heart. Obstructive PE, blood can't get past that pulmonary embolism, so anything past that is not going to get oxygenated, not going to get back to the heart because you've blocked the tributary. Some people can have massive PEs where it actually will sit in the bifurcation. It'll cover both of that area so that both pulmonary trees are blocked. You can block off the entire lung. So these PEs can get pretty crazy. So we get reduced venous return to the right atrium because we're blocked on the venous side. On the pulmonary side, what are some causes for this? Here's your pericardial tamponade. So for that one, tension pneumothorax, it's just a sudden collapse of the lung. Constrictive pericarditis. Remember, restrictive. What do these, well, the bottom three have in common? Filling problems, right? They have filling issues. And if they have filling issues, it's a volume problem. And that's why you have a decreased preload. It's not the heart can't get the blood out. It's that there's no blood in the heart for the pump to get out of the heart. Because preload is being reduced due to the obstruction in the area. And in these cases, the obstruction is the heart can't relax and it can't fill. The heart can't fill, there's nothing to pump out. Okay? Any questions about the different types of shock? There's only 4. Yes?
On the last slide in that diagram, you said that you're increasing the oxygen demand, but that leads to ischemia?
Because there's no blood to get to the, because you have, the demand for oxygen has gone up, but the problem is the tubes, the coronary arteries are blocked. So you can't get blood there because you're having a massive infarction. So that artery is blocked. So the muscle doesn't work.
So it's because of the arteries being clogged that you need to...
Yep. Okay. Last little bit is on thrombosis and then peripheral arterial disease. Yes?
With the previous slide, so those 4, like tension pneumothorax, etc., those cause obstructive
Yes.
shock? Okay.
Not all the time, but they can be the cause. So if someone comes in with an obstructive shock or they're in shock, you don't know why, and you do your history, and also you do an x-ray, and they're like, oh, their lung is collapsed. That's probably the cause for their shock issues. So always try and find the underlying cause. Because of these 3 things, yes, this is the underlying cause. This is what caused them to have an obstructive shock. But here's the thing with medicine. If you misdiagnose this as an obstructive shock and you think it's a hypovolemic shock, what is your treatment going to be? Massive, massive amounts of fluids. Will that fluid do anything for this patient? No. You have to know the underlying cause so you know how to treat it. If this cause is pericardial tamponade, you do an echo and that heart is, what are the signs of Beck's triad? Pericardial tamponade, what are the 3 of them? Hypotension, JVP, muffled heart sounds, okay? if you hear these things and you do an echo and they got a pericardial tamponade, you're going to do what's called a pericardial window, where you strip the pericardium, the fluid comes out, and then they're okay. So you see now, while they're going to come in with these types of symptoms, but if you get the diagnosis wrong, you're not going to effectively treat your patient because the treatment's not going to help them. So you have to find out, why are they in shock? Any patient comes to the hospital, why are you here? Don't tell them that like that. But your goal is, how can I get you out of the hospital as fast as possible? You don't want people in the hospital for long. Yeah.
When somebody goes into like any of these shocks, like how long do you feel like they have until it's like?
Depends on the severity of the issues. If the hypovolemia is due to just dehydration from massive vomiting and diarrhea, that's, you'll go into low blood pressure, but just get some fluids and you'll be okay. But if you have you slice your leg and your femoral artery is wide open and every blood squirting across the room, that you're going to lose blood a lot faster with that, so you'll decompensate faster. It just depends on the severity of the issue that caused you to go into shock. How much of the heart muscle was damaged in an MI? Obviously, if 80% of that left ventricular wall function is gone, that's a much more severe cardiogenic pump failure than a 20% loss. So it depends on the severity. Okay, thrombosis, arterial and venous thrombosis. This is where definitions matter. The thrombus is stationary. So whenever you hear the word thrombus, that is the original clot. That's where it started from. If you say it's an emboli broke off that clot and traveled somewhere. So that's why it's a pulmonary embolism, because that clot originated in the leg where the deep vein thrombosis was, that caused an emboli to form, breaks off, travels in the circuit, lodges itself in the pulmonary vasculature, and now you have a pulmonary embolism. Again, can result in ischemia due to decreased distal flow, depending on the size of this thrombus. How much of the vessel is occluded? Going back to what you learned about CAD, how much of the vessel needs to be occluded when you start getting unstable angina when you're walking? What percent has to be occluded before you start getting chest pain with walking with stable? 90% occlusion. With exercise, when we stress them, we know only a 50% of occlusion is needed before you start seeing EKG changes with stress. Common areas for these thrombuses to form, obviously these are the ones that are going to cause issues with arterial problems. Your coronary arteries causes an MI. Cerebral arteries, stroke. Mesenteric arteries, mesenteric ischemia, where you get this bowel obstruction that cause a lot of problems. Renal arteries, we talked about that a lot yesterday. Renal vascular hypertension. So it just depends on where these things develop. Where does the thrombus develop? Not going to happen in all of them, but it'll happen in one of them, and that's where you're going to get your symptoms from. Risk factors for clots. Immobilization is the big one. Okay, metabolic syndrome is here as well, advanced age, tobacco use because it tears up your arteries, therefore any intimal injury to the endothelium, repair has to happen, and that's when clots start forming. And cancer is there as well. The immobilization is the big one though. We'll talk about that in a second, mainly in your legs. So there's this Virchow's triad. You need all three of these things. Increases your risk for developing a thrombus. Endothelial damage. Smoking is going to cause endothelial damage. Diabetes. Okay, those all cause uncontrolled hypertension, vessel damage. Next one, alterations in blood flow. Either it's turbulent or slowing of the blood flow. Remember, clotting is a slow process. Those processes need to be in that area for a little bit. In arteries, they move too fast. That's why when the arteries start to slow down, those clotting things can start to kick in. And the last one is increased coagulability of the blood. Is your blood coagulable? Do you have any of these genetic disorders that lead you to have increased clotting? Or the opposite, you don't clot and you bleed everywhere. So the big one is obviously hypercoagulability. What's something that women can take that increases the hypercoagulability of the blood? Birth control. So birth control, if you're on it, you got one risk factor for a DVT. If you go on a plane ride to other part of the world, you don't get up and walk for 20 hours. Now you got your immobility. If you have another issue underlying that causes vascular damage, you smoke or whatever, now you got your three factors. They all come together in a perfect storm. You can develop a thrombus. One of the things you'll look at for deep vein thrombosis is did you go anywhere? Did you go on any very long road trips? That's why they tell you either wear the support stockings on your legs to keep the blood moving, or get up and walk around to keep that blood moving so it doesn't just pool in your legs and can clot. So those are the Virchow's triad. Now, once this thrombus forms, there's a couple of different pathways it can take. It's going to get bigger, or it can lyse, it can break apart to smaller pieces that our body can absorb and break down. It'll propagate, which is getting bigger. It can organize, which means it's going to become very firm. It can canalize, which means I'm going to do a cross section here. So here's our artery, and we're going to have a clot going in the middle of it. But what happens is a hole will form in the middle. Blood can still go through that because you're canalizing the clot. You're making a little hole so blood can get through it still. That's canalization. So a new lumen forms within the thrombus. The last thing, embolization. This is where it breaks off and starts traveling throughout the cardiovascular system. And once it gets to a size, capillary or small arteriole, that is smaller diameter than the clot is, now you've lodged that clot, and now you can form or put that patient into an obstructive shock because now you've caused an obstruction. Not you, but they did. Okay. So arterial embolus, arterial. So make sure on their test you read, is it arterial or we're talking about venous? Make sure you know the difference when you're reading the questions. May have begun as a thromboembolus that was eventually dislodged from the vessel intima, travels to a distant spot where it lodges and produces an obstruction. Thromboemboli from, again, left side of the heart can cause a stroke. Thromboemboli, deep veins, so your DVT, return to the right side of the heart, and they can cause a PE. Likewise, if you have vegetation on your tricuspid valve, mainly IV drug users, they can cause PEs because they already have the vegetation on the right side. We're on the tricuspid valve. Breaks off that, it's going to go into the lungs. So that's where that can cause a PE as well. So this is arterial thrombi. Deep vein thrombosis, again, Virchow's triad. So venous stasis, post-op immobilization. What do they put on people's legs after surgery if they're going to be in bed for a while? Compression stockings, or the SCDs, the sequential compression devices. They squeeze your calves, which is going to activate what? Remember the skeletal muscle? As your calves squeeze and you start walking, that's going to cause a muscle pump to get the blood moving. By having those SCDs on, it keeps the legs squeezing so that the blood will move so it doesn't just pool in your veins, causing a clot. Do you have a question? Okay. Prolonged bed rest, again, people who don't do anything, they get clots. Vessel wall injury or inflammation that can be due to trauma or surgery. Hypercoagulability, here's your oral contraceptives, or a history of cancer. So these are the things that kind of put you at a higher risk for one of these things. And if obviously you have the perfect storm and all three are present, then your risk for a clot goes up even more. Yes?
So in people with like heart deformities, can a PE travel to the other side?
still got to get through all the lung system first. You're gonna get stuck in the lungs because you have to go through all the pulmonary capillaries too.
If there's like a hole though?
If there's a hole, then yeah, that can happen for sure. But you would find that out on echo. You'll hear some murmurs when you get to cardio. They'll talk about there are some murmurs with atrial septal defects or ventricular septal defects. There's things you can do to see if there's one's called a bubble study, where you inject bubbles into the on the IV, and you'll see all the bubbles form in the ventricles because it comes up. And if it starts crossing the side, then we know you have a hole in your heart because those bubbles shouldn't be on the other side. So you can do stuff like that. Okay, so here's a little. Okay, here's our DVTs. Signs and symptoms. Edema to affected extremity. So usually with a DVT, one-sided. Their right leg is going to be swollen compared to the left. In congestive heart failure, fluid overload due to kidneys not working. It's a systemic overload of fluid, so the whole body swells. So with congestive heart failure, the legs, both legs, will swell equally. They both have the same hydrostatic pressure increase. In this case, there's a clot in the veins preventing blood from leaving that extremity. So it gets bigger and bigger and bigger. And you can see on this picture how that left leg is massively swollen compared to the right leg on this patient. So obviously this is the leg that has the DVT in it. Where is the DVT? You need to get ultrasound to figure out where it is. The treatment is going to be the same though. You got to get rid of that clot. They're going to have to go on blood thinners, Coumadin, warfarin, whatever you want to put them on. But they need to be on something to get rid of that clot. They're going to have heat and tenderness to the site. Why are they going to have heat? All the blood's stuck in the area. Blood's warm. It causes the warmth. Tenderness. It's swelling to an area. You're not going to be able to move it very well. They're not going to be able to bend their leg with all that swelling going on. Positive or minus Homan sign. You guys know what Homan sign is? You guys do it in PD? Okay. So basically it's pain in the back of the calf with extension of the foot. So that's called, but it's not very specific for DVT, so they may or may not have this Homan sign, but if they don't have it, don't be like, oh, they don't have a DVT because they don't have a Homan sign. Still get an ultrasound and see what's going on. Question?
Could you get a bilateral DVT?
You could, but if you got a bilateral DVT, and you can have these as well, they're called saddle emboli. So if this is your femoral vein on the left, and here's your femoral vein on the right, they're going to merge to come up, right? If you get a clot right there, now you've occluded both sides. That's called it's very rare that those happen, but they can happen where both legs are cut off. So that's it on the thrombus. Now the last little bit is on peripheral vascular disease. Okay, so we're going to talk about the arteries and the veins. When you guys are studying these last two blocks, thrombosis and arterial and vascular disease, you have to make sure you differentiate. Is this a venous problem or is it an arterial problem? Okay. So arterial disease, obviously very large peripheral arteries of the legs. Frequently the etiology is atherosclerosis. You're going to have buildup of plaques, these fatty streaks in the arteries that feed the legs. And this results in ischemia and pain, significant limbs inactivity. What is this called when they get pain when they walk? What kind of claudication? Intermittent. Okay, and it comes and goes. It's even right here. But again, they're walking. The demand for oxygen in those muscles goes up, but you have peripheral arterial disease. So the amount of blood that can get into the legs is diminished. Supply and demand don't match. You get pain. This may be caused either by a thrombus in the area or even an emboli. The emboli that leaves the left atrium, that goes left ventricle, that goes into the aorta. Not all of them shoot right up to the carotids. Some of them can get through the subclavian artery and go down the aorta and go down the abdominal aorta, femoral artery, and then they'll get lodged in a small vessel in your leg. That is another way to get an arterial emboli in your lower extremities. It can come from the heart. So signs and symptoms, intermittent claudication is usually the first one. There's not enough blood supply, so mismatch, they get pain when they walk. Paresthesias, what are paresthesias? Numbness and tingling. Okay, if you sleep on your arm wrong, you wake up, it's like pins and needles, that's a paresthesia, it usually goes away. Why does it happen? Lack of blood supply to an area, nerves don't get enough perfusion, they get irritated, and you get the symptoms. Ischemic ulcerations, what are those? What's happening? There's lack of blood supply. Gangrene will happen later on. Non-healing wounds. People aren't healing. Think blood supply. Why is blood not getting to your feet? So when you guys are in PD, what do you guys do to check your vasculature in the legs? How many sites do you check usually? So you have the femoral artery, which we avoid, but you still have the femoral artery, popliteal, anterior, and dorsalis pedis. So there's 4 of them. If I can't feel a pulse in the femoral artery, but I do feel in the popliteal and the dorsalis pedis, is there blood getting down there? Yes, because you felt a pulse downstream. So you start at the top, okay, I feel a pulse, no, I don't feel a pulse at the feet, but I felt it at the knee. That means the blockage is probably somewhere between the knee and the foot, because I can feel the pulse in the leg, I can feel it in the femoral artery, I can feel it in the popliteal, but I don't feel it in the foot. So that's why you have to do things in a certain order to figure out where is the problem. Okay. So this is what it looks like. These peripheral arterial disease has these 6 P's: pain, pallor, pulselessness. Obviously, there's no blood getting to that area. You're not going to feel the dorsalis pedis or whatever. Paresthesias, poikilothermia, and paralysis. So 6 P's for peripheral arterial disease. Does venous insufficiency, which we're going to talk to you in a minute, does venous insufficiency cause pulselessness? No, because the arterial side is what causes the pulselessness to happen, or the pulse for you to feel it. It's an arterial pulse, not the veins. Okay, so you can have some of these in chronic venous insufficiency as well, but not all of them will be there. So here's our chronic venous insufficiency, also known as venous stasis. If you want to see this, go to Disney and just people watch. You will see it in a lot of people. Okay, results when the valves in our veins are incompetent. Remember, we have one-way valves in our veins to promote all the blood going back up to the heart. So when we're standing up straight, the blood will want to come back down due to gravity, but we have the valves there to prevent the backflow. But when these valves become incompetent, blood is going to start to fall back down and it'll start to pool in your venous system. Major culprits: superficial femoral vein, anterior posterior tibial veins, and your perineal vein. So loss of wall tension, because now our valves don't work, so they're being pushed out. Remember, veins don't have very much musculature on them. Nothing's going to hold it tight, so they just get floppy. Yes?
So could we say that chronic venous insufficiency causes DVT? Like, is that possible? No.
It can,
Okay.
if they have the other things. So this is going to show your immobilization, but you still need hypercoagulability, and you still need vessel damage to make the triad. So loss of wall tension, stasis of blood, and when blood sits around, it's going to clot. You get progressive edema because we're also increasing our hydrostatic pressure in the veins. So with increased hydrostatic pressure, it's going to push the fluid out, cause edema. So they're going to have shiny, thin, atrophic skin. Dark pigmentation right there, so that's what you're going to see if you go to Disney and watch people. This brown pigmentation in the lower extremities, that's actually blood, I think, getting into the skin, causing those issues. Stasis ulcers right above the ankles, usually right over that malleolus. You'll see these bony areas are very prone to ulceration. So right on that malleolus, there's not very much fat there. It's that bone and the very, very thin piece of skin. Same thing with your coccyx and your tailbone. When people are bedridden for a long period of time, it can push down and push out the blood, causing ischemia, and then it rots from there. Itching, dull pain, what's that called? Anyone know what the medical term for that is? Itching, pruritus. And edema, especially at the end of the day. Why? They're standing all day. So when they go to bed at night, now gravity is not an issue. What do you think happens to their legs in the morning when they wake up? They're less swollen, almost normal. So ask your patient, if the swelling is present all the time, it's probably not venous insufficiency. It could be heart failure or volume overload or something. But if they say, you know, I go to bed at night, I wake up in the morning, my calves are fine, but throughout the day they get worse and worse, tell them that wear TED stockings, the support hose, the compression stockings, whatever. That will help with that. Yes?
If someone has like stasis dermatitis, is that related to chronic venous infection?
Yes. Here's your, your ulceration going on. Again, these are stasis ulcers, painful, pink-red base, irregular, uneven borders. Medial malleoli is a common area for these types of ulcerations. Okay, we're done. Come back at 11 and we'll start our reviews.